Good afternoon. Let's see what is the role of steroids in diabetic macular edema. We all know what is the pathophysiology of diabetes. Hyperglycemia causing breakdown of blood-retinal barrier with releasing VEGF and inflammatory mediators, ultimately leading to development of macular edema. So if you are injecting anti-VEGF, we are dealing with the vasogenic arm. So what about the inflammatory arm? Here comes the role of steroids. In diabetic macular edema, there is upregulation of various interleukins and adhesion molecule, and moreover, there is altered expression of aquaporins in Muller cell, causing redirection of fluid within the retina, causing more and more retinal edema. So what is the role of steroids? Steroids have special role in long-standing edema. Why? Because in chronic edema, the VEGF level will come to a normal level or sometimes even low, along with high levels of inflammatory markers. So that is why some of the recalcitrant macular edema cases are showing better response to steroids than anti-VEGF. So steroids are not only anti-inflammatory agents. By downregulating the this expression of VEGF agents, they are also anti-angiogenic. Steroids are always second-line agents after anti-VEGF, but these are some of the specific indications in which you can have a trial of steroids. Among these, most important ones are persistent diabetic macular edema, patient with multiple comorbidities, and pseudophakic eyes. So what is persistent diabetic macular edema? According to the DRCR-NET and VISTA-VIVID studies, it is failure to achieve a centrofoveal thickness of less than 250 microns or at least 10% reduction for a period of 6 months, even after injecting 4 monthly injections of anti-VEGF over a period of 6 months. So in this persistent diabetic macular edema, steroid has better role than anti-VEGF. So there are certain biomarkers which will tell you which all subset of patients will respond better to steroids than anti-VEGF. These are presence of baseline subretinal fluid, severe extensive submacular exudation, and hyperreflective foci. We all know what are the contraindications and documented side effects of steroids. So what are the different options? Among these, topical and anterior subtenon, they won't reach sufficient concentration in posterior segment, so they are not at all used for treatment of diabetic macular edema. So the different options are posterior subtenon, intravitreal injections, implants, or suprachoroidal injection. Posterior subtenon in the earlier studies have shown better result with subtenon. The advantage is it is less invasive with lesser side effects compared to intravitreal route. But protocol E study of DRCR-NET have not shown any promising result with posterior subtenon. So nowadays we prefer intravitreal route compared to posterior subtenon. We can inject triamcinolone in a dose of 2 mg or 4 mg, but the problem is it is an off-label drug and the FDA is not approved yet for treatment of diabetic macular edema. So why we are giving DME? That is because of the result from protocol I trial of DRCR-NET, in which they have shown IVTA plus laser has efficacy almost similar to ranibizumab plus laser in pseudophakic patients. So, but the problem with posterior subtenon and intravitreal is it is shorter lasting, so we have to inject repeatedly after every 3 to 4 months. So if we inject some slow release implants in a lesser dose, it will be more beneficial to patients. So that has led to the development of steroid implants. These are preferred mainly in patients who are difficult to follow up or victimized patients or macula showing extensive exudation. Among these, most important one is biodegradable implant, that is KSOS2023 is the commonly available drug in a dose of 700 microns. And it is the one approved for use in diabetic macular edema by FDA with a duration up to 6 months. Fluocinolone implant is a non-biodegradable device. The advantage is it will last up to 3 years. As the duration increases, definitely the complication will also be more. So it is less use, and options are Iluvien, and Rectisert is mainly used for posterior uveitis. It is not approved for diabetic macular edema. And suprachoroidal injection is the newer promising route in which there is direct targeted therapy to the retina and choroid with a better safety profile. We have to use special micro needle, and so many studies are going on the suprachoroidal injection. So this is nutshell about the different options among steroid. Now we can come to different case scenario. In our medical college setup, there is no provision for anti-VEGF, so we are injecting intravitreal or subtenon steroid in selective cases. So in first case, patient presented with very dense cataract. He had multiple comorbidities like stroke and CAD. And this is the fundus picture, and this is the baseline OCT picture. So the anti-VEGF was contraindicated. We have given IVTA along with catheter surgery. And this is the picture at 1 month, and this is the OCT picture at 3 months. The vision was improved to 6/9. The other eye also, patient underwent the same procedure, and he got 6/9 vision. In the second case, the patient was diabetic, and you can see it is a very dense brown cataract in a poorly dilating pupil. The surgery was done with pupil dilating devices, and postoperatively patient developed pseudophakic macular edema. And with IVTA, this is the 6-fix picture with 6/12 vision. In third case, the patient presented with lens-induced glaucoma. There was soldo dialysis, so we could implant only the iris glow IOL. So we have given the patient developed postoperatively pseudophakic macular edema. We have given the posterior subtenon. The vision was surprisingly improved to 6/6. And this is the last case. You can see it's a center involving macular edema in a very dense cataract. The fundus, the view was very hazy. We could take only a line scan. And we have given subtenon, posterior subtenon along with catheter surgery. And the vision was improved to 6/6 at 3 months. So if we carefully, even though it is a second line agent, if we carefully select some of the patients or some of the cases, steroid could do some additional benefits in diabetic macular edema. Thank you. Thank you, madam, for this opportunity.
That was a good talk on steroids use in certain, especially during cataract surgery or after cataract surgery. But when we do a treatment, we should also know when to stop medical treatment. That is the most important. Can't keep on injecting in a patient who will not gain vision. So that is our next topic by somebody who is, of course, going to be our next president.